Hi everyone, I'm Dr. Joe Sarantino, and today I'm going to talk to you about the clinical applications of Sigmolecs technology through monodose devices. Basically, we're going to see the mechanism of action, the applications in clinic, the practitioner's role, and the reason for the in situ format. How the monodoses work is basically through intracellular signaling by introducing polypeptides or the intracellular signaling of the peptides. Basically, we are using a highly penetrating hyaluronic acid conjugate gel to deliver peptides through an in situ application. These peptides induce intracellular signals. They target and activate cell lines that then induce pathophysiological responses that activate repair and regenerative mechanisms. The signaling molecules act directly on the cellular environment to call cells that are present in that cellular environment to reorganize into tissue. This action is immediate upon the in situ application of the monodose, and we are going to see that in the next few slides. Now, the signaling can be, or the action is immediate because the signaling bypasses pattern formation of gene codes by acting directly on the cellular environment. So upon application of the monodose, once there's penetration, which is immediate, the activation or the signaling at the subcellular level is immediate. So here we see the permeation, and I'm showing you on the left a drop of water that is going on the forearm, and we see that the drop is just simply slipping off of the forearm, and not leaving any kind of evidence of penetration here. It's going back to normal. Comparatively, on the right, we have a drop of a monodose gel that is being applied to the same area of the forearm, and we see that this drop is going to get larger before our very eyes. This is a real-time infrared video. So you can see that it is getting larger. Now, the blue nucleus here, the middle, is getting darker. And this is evidence of subcellular or subdermal penetration, and eventually, as it gets darker and darker, it is subcellular penetration. So the action of the signaling molecules is immediate upon application of the monodose, as I mentioned in the previous slide. We're going to see some other drops being applied and the same thing happening. Now, the shapes, the applications seem to be taking shape as well, and this is cellular response. So it is cellular response to the signals that are actually taking shape. We see here is a little bit of a different shape than here. We see again the subcellular subdermal evidence of the dark nucleus, and then the changes. We can see it working, going, actually penetrating, and now it's changing shape and going from light to dark. This is subcellular penetration, very deep penetration, and we have the cellular response, which is actually responding to the signaling in the form of shapes. So these different shapes the different really shapes or subcellular responses of the cells at the subcellular level that are reacting or responding to the signals. So they're actually taking shape. So we see this is real-time infrared video. It cannot be altered, and we see here real-time penetration of the monodose upon application. It is immediate. In this slide, we see cellular response in vivo. The peptides applied in situ leave a signature, a vibrational pattern that can be seen as spatial expression through confocal imaging techniques. So the image here shows cellular response to signal induction by mesenchymal stem cells to myocytes. So basically from here into the myocytes we have the action, and these are all the little dots are basically confocal imaging techniques that are showing spatial expression patterns. So we see that there is real action at the subcellular level in regeneration. There are many factors involved in regeneration. The dynamic at the molecular level is unique and complex, but most especially there's an intimate relationship between the extracellular matrix and the immune response. The more evolved the organism, the narrower the capacity to remodel the extracellular matrix becomes, and so there is much less regenerative capacity in an evolved organism, such as higher mammals and humans, compared to less evolved primitive organisms such as salamanders, newts, etc. So in humans, for example, there's a tendency to fibrosis during repair because there is a fast deposition of collagen types rather than of hyaluronic acid and other provisional matrix components such as fibronectin or tensin. Different ratios of these components will manifest different regenerative outcomes and require different pathways. The monodoses enable programming of remodeling pathways. So the practitioner now has more control of laying down ECM or extracellular matrix components and has more capacity to have more precision in regenerative techniques. So again, the monodoses are enabling more control of the composition of the architecture of the extracellular matrix. The composition of the extracellular matrix affects the whole repair process and further affects the concentration of growth factors, chemokines, blood cells. For example, if there's a weak signaling of neutrophil activation, this can cause faulty immunodeficient signatures that can cause tissue rejection, stem cell rejection, upregulation of inflammatory cytokines and chemokines that result in fibrosis. So it is important to have something that enables us to have more control over the regenerative pathways, and monodoses are one way of doing this. They basically, in a very simplified way, they basically trigger the in situ application is the trigger to instill the signal, to signal the subcellular cells that then activate the pathways in the extracellular matrix and cause components of the extracellular matrix to interact and deposit regenerative pathways and more signals and activate regenerative pathways. So the monodoses are definitely very active in vivo. They are enabling the practitioner to control, or to at least have some control over, the cellular behavior, to be able to tune the architecture of the extracellular matrix and regenerative pathways. So it's important to understand that the monodoses are an in situ, an on-the-spot application, so that you can actually zero in on your repair area. There is no need for serum concentration in this particular medical device. It is simply a topical application that enables, that delivers peptides to the area to be treated. And it must, however, be patched. And what I mean by patched is that it has to be covered. The monodose is simply a monodose. It's basically a little bit more than 1 milliliter of gel that contains the different ratios and combinations of peptides that are going to induce those signals at the subcellular level. But it must be covered. And the reason it has to be covered is basically to prevent oxidation reactions, because oxidation will change the effects of the base gel. Now, it's not going to be dangerous. It doesn't cause dangerous effects, but it will significantly reduce the effect of the monodose. So the monodose is not meant to be a rub. It is meant to be covered. Now, the cover also gives you some other a little bit more of an edge for the patients as well. From a holistic point of view, it can give the patient a psychological effect that they are receiving a high-tech application, which, basically they are, because the monodoses are very high-tech. The technology is very innovative. And it also allows you to visually instill the area of application, because the practitioner's role is very important. The practitioner must determine the area to be to receive the in situ application. Basically the physician, the practitioner, must diagnose the problem. The monodoses are available only to practitioners. They are not available to the consumer, and the reason for that is that we need the practitioner to make the diagnosis, because they are in situ and they are direct. They induce direct action at the subcellular level. They need to be applied to the right spot. So it's important for the practitioner to have the role of the diagnostician. Now, you can send your patients home with the patches or the monodoses, and by already applying one, they will have a visual of where the patch should go. Of course, you need to give them instructions, and there's all kinds of material available on how to apply them, to make sure they're patched properly. Basically, it's very simple. You choose the adhesive Band-Aids patches that you prefer. You apply the monodose to the island of that patch or directly to the spot on the patient, and you cover it with your patch. I don't recommend that you get them wet, even if you're using patches that can go in the water, I still recommend that you do not, the patients don't go swimming or take a shower with the patches. The patches need to be left on for a minimum of 2 to 2.5 hours, and there is no real maximum time period. You can leave them on overnight. It's important to use sterile methods, just as though you would give an injection, because remember that there is great penetration here. There's penetration as deep and probably deeper than a subcutaneous injection, so it's important to swipe the area before you apply the monodose. Swipe the area with alcohol as you would do if you were giving an injection. So swipe the area with alcohol and apply your monodose, patch it, and you're done. So we're going to look at the first monodose. We're going to see 3 of them today. We're going to see the anti-inflammatory, the AI, which stands for anti-inflammatory. It's basically an anti-nociceptive and an anti-inflammatory. It contains polypeptide 6 that codes for interleukin 10. So it really basically, its basic use is to mediate the inflammatory response. And macrophage switching is essential in mitigating the inflammatory response. Macrophages induce specific pathways in cells, and these pathophysiological responses are actually different for inflammation than they are for regeneration. In tissue, particularly musculoskeletal tissue, macrophage response is weak and anti-inflammatory signaling is muted, especially in humans, because their immune responses are activated by mostly environmental adaptation sequences, and so they react more to insults by bacteria or viral triggers rather than from trauma and injury or from aging tissue. Mammals have, or higher mammals and humans have, evolved immune responses to deal with environmental adaptation and insult by viruses, and that has given them a different set of cellular receptor factors, giving tissue regeneration and wound healing a backseat. But these primordial signatures, as I call them, are still there and can be activated and guided to regenerative tasks by specific molecules such as proteins and peptides. And these differences in epigenetic immune responses particularly affect polypeptide 6 signaling and in turn macrophage activity. Innately, macrophages do not produce a lot of interleukin 10, and immune signals are weak and very specific to their source stimuli. So for example, in mammals, inflammation from a bacteria or a virus will emit strong signals and call macrophages to respond, whereas trauma, as in wound and tissue injury, the signals are very weak and macrophages are quiescent. So by adding monodose AI, you're basically strengthening the interleukin 10 signaling and calling macrophages to the in situ location. So the area of your treatment in need of anti-inflammatory and anti-nociceptive effect will be covered. You're increasing the signal strength to upgrade the inflammatory response for tissue repair and regeneration beyond the organism's innate ability. And this is basically what the anti-inflammatory monodose does. It makes your anti-inflammatory application much stronger, and it induces very strong interleukin 10, which is basically, you can consider that anti-inflammatory signaling. So in this slide, we see the AI monodose, the anti-inflammatory monodose in action. We're going to see, we see here the metacarpophalangeal joint, an acute flare-up of the joint, and we see all the red area, of course, here that is extremely inflamed. In a moment, we will see the application of a drop of AI monodose, and we will see, of course, the penetration as we did in the previous videos, but we will actually see the action on the inflammation. And keep your eye on this area here, because you are going to see a very quick attenuation of the swelling. And here is comes the drop. This is real-time infrared imaging, real-time video. So there's the drop. And we can see, as in the other videos, how quickly it penetrates with the blue center. And it is getting larger, and already in the area that I had indicated is already all this area here, we are seeing changes in the color already. As the video progresses, we see more and more changes in the swelling, and so as you can see here, there's already a large amount of the redness that has disappeared. The joint, the spot right on the joint is getting much darker as well. As we can see, it's penetrating deeper and deeper into the joint to attenuate more and more of the swelling. We see a lot of this redness disappearing. It was much redder before, as you will see in the next slide. There's a burst of 1 second advances of the video. But again, this is real-time infrared imaging, so we have this was the original, and we could see at the end how much attenuation was taking place from the application of the AI monodose. In the next slide, this slide we see a photographic burst following the video that we took, and the basically 3 minutes after the application of the AI monodose. So we see in the first photograph here that there is only slight spots of red still there, so the swelling has been quite attenuated quite a bit. In the next burst, these photographic bursts are 1 second apart. We see that the red spots are again much softer. There's a lot more of the regular color, shall we say, a normal color coming back. The swelling is gone, and in this last video, this last picture, we see that there's hardly any, there's very slight red spot left, and this is basically after 3 minutes of application of the AI monodose. So 3 minutes in total with perhaps the last one is maybe 1 second more that you can add on to that. So 3 minutes post-application in the acute flare-up of the arthritic joint. This is what you're getting from, we saw it working in the video. 3 minutes, we have most of the swelling gone, and finally 3 minutes 1 second, it is almost completely back to normal. So protocols with the AI monodose are quite straightforward. You can review them later with the slide, but basically the application of the AI monodose is the easiest because you basically apply it right where it hurts. So right on the area of pain or swelling or its very close periphery. So you apply it on the area or superior to that area. Now, superior to the area, you usually do that when you are mixing it with the other monodoses that we're going to see in a little while, the ST, which is a regenerative, an overall regenerative monodose, or the CR, which is for osteoarthritis and cartilage repair. But in general, the AI is very easy to apply. It is clearly for pain and inflammation, and you apply it basically where it hurts. The slide is quite self-explanatory, so I'm not going to stay on it too long because it's quite self-explanatory. And as we go on with the webinar series, we will see more and more protocols, and they'll be more and more detailed with more infrared imaging of before and after and so on and so forth. The ST monodose is an overall regenerative formula for repair and for induction of hematopoietic components. It contains polypeptide 29, which codes for interleukin 3, and tripeptide 1, which codes for FGF1, as well as some other sub-members of the FGF family. Signaling by these peptides engages cascades that can actually sort cell types and target different tissue types. So that means that they can literally program regenerative processes to become tissue specific. That is, they can become limbs, cardiac, brain cells, and so on. Tripeptide 1, for example, typically mediates the extracellular matrix by binding to heparin sulfate proteoglycans, where they then flood the extracellular space and engage initial regenerative processes. But this is just one example of a tripeptide 1 pathway. Polypeptide 29 delivers hematopoietic factors and signals that cause more cellular differentiation responses, but it does so in vivo with the monodose. So this establishes a hematopoietic niche that provides a medium for cells in vivo. Because remember that regeneration is tissue specific. For example, mesenchymal stem cells express differently either in quantity or in cell cycle entry for different tissue. For bones, for example, they are very subject to differentiative and proliferative measures in pressures in vivo. So, for example, there would be dwindling numbers in tubular bones that are quickly exhausted and unresponsive to signals, whereas in cancellous bone it would be the opposite. There would be large numbers and they would be very responsive. So the osteogenic and hematopoietic microenvironment holds a dynamic that is highly competitive for stimuli, for signal responses, and for engaging pathways. So they compete at each other's expense, so to speak. So that's why stem cell therapy is not always consistent and requires some input. Sigmolecs provides you with the way to upgrade your stem cells by stem cell modalities by providing this input, this precision programming. And we will see some protocols using ST at the end for regenerative processes or procedures by simply applying one monodose on a post-treatment of stem cell therapy. But overall, it is for repair and regenerative conditions, and it does provide overall regenerative cascades for all conditions, not just stem cell therapy, but for all many clinical procedures. Here we have a protocol for the ST monodose. It's pretty self-explanatory. I just wanted to mention that you can use different sites. You don't have to use just one in situ site like in the AI monodose, where it's really on the area of pain. Obviously, if there are several areas, you can use the AI on the several areas, but typically with the ST monodose, and later we'll see also with the CR monodose, you use them in pairs. You use them on either side of the joint, or you use them with a joint and with a tendon or ligament that is associated to that particular condition. So you can use, oftentimes you're using 3 to 5 patches per application with the ST or the CR. So on either side of the ankle joint for treatment and prevention of runner's syndrome, for example, and on related tendinopathies, you can treat both the knee and the ankle in this case, for example, and you would be applying your ST to near the joint and to any ligament or tendon that is within your protocol range. So it is not, there's no restriction on how many monodoses that you can use. So this patient had considerably advanced osteoarthritis of the knee. She had a lot of pain, very little mobility. She had in this, here we see the synovitis in this line here that I drew in, a lot of synovitis. I don't know if you can see it. It's a little bit darker orange. This is a lot of synovitis. She had a injury to the sprain of the collateral ligament, and she developed synovitis as well. She received pre-treatment with, well, not pre-treatment, but the first treatment was with the version of the ST and the CR monodose, as well as the AI. She received the devices for approximately 1 week to stabilize the joint and the pain, and it did the job. The image on the right was taken a month. This image here was taken a month following the first week of application of the 3 devices, and she had regained about 70% mobility at that time. We can also see that there is no synovitis And there is then in the next image here, this image, after a total of 4 applications twice a week for 2 weeks, she was pretty well restored to a full range of motion. And we can see that this area here, the ellipsis shows a marked thickening of the trochlear groove, which indicates regeneration of cartilage tissue. The CR monodose is basically for osteoarthritis, but it is overall for the repair of joints because of the cartilage rebuilding capacity that it has and the affinity for the overall mechanics of the joint. So here we're saying it's for the prevention and relief and repair of osteoarthritis and other joint conditions as well. But the operative area is joint conditions due to cartilage degradation, and of course osteoarthritis is all about the loss of cartilage. So we are targeting osteoarthritis, but again, it is very appropriate for all joint conditions. It contains polypeptide 93, which codes for connective tissue growth factor, which is also called IGF binding protein. And it also contains polypeptide 85, which codes for FGF9 and some other subgroups of that family. So in a typical osteoarthritis protocol, it's really about building cartilage, as I mentioned, and of course strengthening the connective tissue matrix and overall joint. So signaling must induce connective tissue binding proteins to activate cellular engineering into laying down cartilage and building joint scaffolds. Both of these peptides cover these areas of repair. Overall, the treatment of osteoarthritis and really any joint repair is heavily related to the connective tissue matrix scaffolding and to cartilage rebuilding and to the mechanics of the joint. We know that cartilage is not innervated and it is avascular. Therefore, it has different inflammatory and repair pathways from bone or soft tissue, for example. In the case of osteoarthritis, cellular engineering has to do more, as I mentioned, with the mechanics of the joint and strengthening of the supporting tissue. Polypeptide 93 is very good at reducing matrix degradation, and it has some anti-inflammatory effect, but it is notorious for flexor tendon repair. Therefore, monodoses of CR can restore flexibility of the joint very quickly. And coupled with the hyaluronic acid base, it can really sustain that flexibility. In dogs, I typically see normal use and strength after 12 days in cruciate ligament joints, as well as in flexor digitorum profundus tendon repair. And this is really remarkable because, once the dogs feel that they have strength, they are not limping and they go back to doing all their crazy activities. And so the fact that we can get this repair within a 12-day period that is sustained and that they're not re-injuring themselves is quite remarkable. So flexor tendon issues, which are usually present, if not to say always exist with osteoarthritis, respond well to polypeptide 93. So does synovitis, which it also for synovitis, which is often accompanying osteoarthritis, as we did see in that case study. As well, flexor tendon injuries. So the polypeptide 93 is very good to cover these areas of the joint injuries. So the formula carries signals that engage a kind of holistic healing area of the joint condition, and well, such as osteoarthritis. Polypeptide 93 also regulates chondrocyte proliferation and differentiation in cartilage repair pathways, signaling the IGF binding proteins, which is absolutely crucial in repairing cartilage and other joint extracellular matrix components. FGF9, on the other hand, halts cartilage degradation and works within angiogenic and osteogenic pathways. And so it's important that we have an angiogenic factor, because we know that cartilage is avascular. So in the overall repair, we really need to have a component that works in concert, an angiogenic component that works in concert with the osteogenic pathway. So FGF9 does this. It works within angiogenic and osteogenic pathways within the extracellular matrix. So CR is really, as you can see, is very appropriate for all joint conditions, and especially those that have cartilage issues like osteoarthritis. So some protocols with CR monodose, of course, again, the CR is pretty much for osteoarthritis. So you basically are positioning it on your osteoarthritic joint. Typically, you would position it on either side. Here we are. On either side of the joint, medially and laterally on either side of the joint. And as we see here, again, you can use several. You don't need to just do one joint at a time. You can use several in several areas. There is no restriction as to how many you can use. I have shown here some red spots which indicate the AI monodose, and that is because often in osteoarthritis, people complain about pain. They also have pain, especially with advanced osteoarthritis. So you can apply the AI in a superior position to where your CR monodose is in order to help attenuate the pain. So again, the protocols are quite self-explanatory on the slides, and you will have other information that holds other protocols. Now, the monodoses, all three of them can be used, are very applicable to stem cell therapy and PRP, and mostly because in vitro culture techniques such as photosensitization, mechanical or incubation techniques, they don't translate to what happens to cells in vivo. There's no, what you're doing outside of the body is not going to be translated in vivo. So all the techniques that are in vitro will not induce proliferation or differentiation or target cells in vivo, as no signaling can be transferred. So Sigmolecs technology can power your in vivo regenerative pathways by introducing peptides that signal and target cells, activating the repair pathways, and thereby really upgrading your regenerative protocols. Because the basic premise is that the monodoses contribute in vivo action, whereas whatever you're doing to your stem cell, your PRP kits, will not transfer into your in vivo application. They may work by upgrading your cells in vitro, but this will not be transferred to your in vivo application. So by applying monodoses to your stem cell procedures, you will be upgrading your protocols and getting better outcomes. You can use them pre or post application, and basically post application is the simplest. It is simply applying one ST monodose over the area where you injected your stem cells, and send the patient home with it. They can take that monodose patch off after 2 hours or the next day. For a pre-procedure application, you can use it to prepare the cellular environment, and you would apply the device in the vicinity of the area to be treated 2 days to 2 weeks, or typically 2 to 12 days before the stem cell procedure. And again, in the pre-procedure application, you can treat several sites simultaneously for this preparatory method.